2020, you see the chest X-ray. She had pulmonary tuberculosis, sputum positive case, and September 2020, only 19-year-old. She was underweight, and the consolidations increased. The X-ray is worse, and we don't know what happened. So we were really worried that the patient has got an MDR TB. So this is the whole sequence. In January, she came with culture positive, smear positive, gene expert positive, rifampicin is negative. So since he was not doing fine, the clinician added streptomycin and levofloxacin was added to the regimen. September again, she came back with the same old things. Sputum was positive, culture was positive, gene expert was positive. Rifampicin again, resistance was negative. And additionally, she developed cecal ulcers also with tuberculosis. So that was also positive. So we decided to send a whole genome sequencing for the isolate as well as the sputum. Direct sputum also we sent for whole genome sequencing. And the sputum whole WGS failed for some, because there are inhibitors, it's very difficult to do a sputum whole genome sequencing. Direct samples, it's very difficult because there are a lot of inhibitors, the amount of DNA may not be adequate, the confidence level may not that great. So culture isolate was positive whole genome sequencing, it was susceptible, lineage 1 was identified, it was not an MDR. So our fear of MDR was removed, that it was not an MDR, it was confirmed. Then we sent her to a higher center. Why she is not responding to first-line therapy in spite of being a pan-susceptible isolate? And in NIRT Chennai, they identified that the TDMs were low. Therapeutic drug monitoring of the drug levels for the antibiotics, the antitubercular drugs were low, and she was ultimately treated with pyrazinamide, amikacin, linezolid, and delamanid. In spite of not being an MDR, she had to give these injectables as well as oral drugs with high bioavailabilities to treat her. Second case, this is a lady, 70-year-old lady. She came with axillary adenopathy, an abscess, and mediastinal adenopathy on February 2020. You see there is pleural thickening here at the time of presentation, and there is a small pleural effusion here. We thought that while giving ATT for the lymphadenopathy, this will resolve. But in August 2020, she became worse. She came with a massive pleural effusion. She was admitted, and the effusion was drained. It was found to be an empyema. But the unfortunate thing in this case was the cultures were always negative. She was caseating granulomatous lesion in case of lymphadenopathy histopathology. The smear was negative. Cultures were positive. Cultures were negative. Gene expert was positive. Rifampicin resistance was negative. Follow-up also, it's the same thing. Cultures were negative. Gene expert was positive. Smear was negative. So we decided to send the pus. That is the only thing that is available for whole genome sequencing. So we sent the pus. We found that INH resistance to INH, Uflox, Moxiflox was resistant. It was not an MDR. Rifampicin was not resistant. Lineage 1. Now, this was the peak of COVID. And this lady said, being a 70-year-old lady, she refused to take injectables, aminoglycosides. She was not able to take it because of the COVID, waiting injectables, many other reasons why she refused to change the antibiotic treatment. So we restarted the ATT. On the first line again, we restarted the ATT. And fortunately, she recovered. This is the X-ray. In February 2021, the pleural effusion has recovered, and she's recovered completely with the first line. We didn't intervene or didn't change anything because of the obvious reasons that she was not able to take additional drugs. But this pleural thickening is still there. That was there even at presentation in the first place. Now, this is an interesting case where we had a brain abscess. This is a child on congenital heart disease, long-term follow-up in our hospital. The child was for follow-up for correction of his heart anomaly, and suddenly the child lands up with a seizures, and we see a brain abscess. The pus was smear positive for AFT, but unfortunately, gene expert came negative. And if you have a smear positive and gene expert negative, the first thing that comes into your mind is non-tuberculous mycobacteria. However, the culture grew Streptococcus species. We treated the Streptococcus species, and culture AFB was negative. Culture AFB was negative. Only smear AFB was positive, and it suggested non-tuberculous mycobacteria. There's no reason why this child should have a non-tuberculous mycobacteria. So we withhold the TB treatment. We didn't consider the TB treatment till we got a whole genome sequencing of the pus done. We did the whole genome sequencing. We found that it was MTB, not an NTM, susceptible, pan-susceptible, lineage 1. First line ATT was started only after whole genome sequencing report came. So this treatment was decided only after the whole genome sequencing came. So there was no reason why to withhold the ATT again. Continued the ATT, and the child recovered from the infection. This is a case of intestinal tuberculosis treated for 1 year. 1 year intestinal tuberculosis was being treated for 20-year-old female. She comes back with a large ileosuas abscess. This is the large ileosuas abscess on the right side. So initially it was intestinal biopsy showed granulomatous lesions, smear was negative, culture was positive, Genexpert was positive, rifampicin resistance negative, first line ATT for 1 year it was given, and then she comes with the large ileus was abscess. Pus was drained, again smear was negative, cultures was positive, rifampicin resistance was negative. In Genexpert, whole genome of pus and MTB isolate both were sent. What did we find? We found some discrepancy. Both were successful. Culture isolate showed INH resistance. The SNP, the mutation was of minimal confidence level. So it may not produce a phenotypic resistance. Pus, all was sensitive. So there is a discrepancy between the pus and whole genome sequencing of pus and the culture, because the culture will need good amount of DNA, good amount of coverage of the whole genome of the bacteria, but the pus may not have achieved that much coverage of the genome because of the low amount of DNA. So there is a discrepancy. So you should understand that if you send a direct sample, it may be different. The whole genome sequencing result may be different because the amount of DNA is not that great. It was lineage 1, not an MDR, continued on first line ATT. Again, this lady must be having some issues with the absorption of the ATT. We sent her to higher center for doing a therapeutic drug monitoring to find out whether the drugs are achieving good concentration, because she's not responding to first line in spite of being pan susceptible. This is the last case of case 5, cervical lymphadenopathy. Now, this was a migrant laborer who was diagnosed with cervical lymphadenopathy, a TB on histopathology. Genexpert was traced. It's not unusual to find trace in extrapulmonary samples, and rifampicin was indeterminate. So we thought that the patient may be having MDR TB, so why don't we send a whole genome sequencing for the tissue as well as the culture isolate? Unfortunately, both of them failed. So it's a mix and match. The whole genome sequencing of both isolate and tissue failed, and we couldn't get a report out of it. So to summarize the whole 5 cases, in the first case, the sample whole genome sequencing failed, culture was successful. Second and third case, cultures were negative. So we were saved by the whole genome sequencing from the direct sample. Case 4, both were successful, but there was some discrepancy because of the amount of DNA and the coverage that was good in case of isolate, and they found INH was there, but the resistance was minimal confidence, so does not confer phenotypic sensitivity resistance. And case 5, both sample and the tissue failed for some unknown reason. Both of them failed, so we couldn't get a report for that. Now, then next we sent 6 isolates which were rifampicin resistant by Genexpert. So Genexpert done on the direct sample was resistant. The culture isolate were available. We sent the whole genome sequencing of the culture isolates only, because that's the best sample to be sent for whole genome sequencing, because the amount of DNA would be very good and the coverage would be more than 99%. Coverage of the whole TB genome would be more than 99%. The depth also would be very good. So 3 samples, and we were surprised what whole genome sequencing told us. Pre-XDR, it's very unusual to get MDR in a center. We have only 1 or 2% of MDR isolates. So we got a pre-XDR. All the 3 were pre-XDR. All were different lineages: lineage 2, lineage 3, lineage 1. If you look at the general distribution of lineages, South India is more of lineage 1. North India is lineage 3. And lineage 2 is well distributed all over India, and it's more commonly seen in Northeast. So we found all the 3 lineages. And when we looked at the history, it suggested XDR, because there was a history of TB, previous history of TB in both the cases. Both 2 cases, previous history of TB was there. And this particular lady was from Delhi. So not a surprise that she had lineage 3. North India, you have lineage 3, South India lineage 1, and lineage 2 is all over India. And this particular also pre-XDR, but we had lost to follow. These cases went to the government for treatment, for further treatment. So we don't know what happened, but they were identified as pre-XDR. It was really surprising. We could have only known by whole genome sequencing that they are pre-XDR. Then 3 more isolates, which were rifampicin resistance by Genexpert. And we had the isolates we sent for whole genome sequencing. It's interesting. You see the first isolate, when we did the DST, phenotypic DST with midget, it was sensitive. Xpert says it was resistant. WGS whole genome sequencing identified a mutation and it reported it resistant. Now, this particular mutation of 435 tyrosine is known to produce low-level resistance. Low-level resistance when the MICs would be on the lower level. The cutoff of 1 milligram used in case of phenotypic DST will not pick up this resistance. So WGS also reported resistance because it has got high confidence. Mutation was found. Xpert also reported, but DST will come sensitive because the MICs are on the lower end. 1 milligram cutoff will not pick it up. So it is a resistant isolate, but phenotypic susceptibility will be seen because it will not be picked up by the breakpoint of 1 milligram. So that you should always remember. That's the beauty of knowing what mutation is there in the rifampicin and how to interpret, make sense of this discrepancy. The second, you see the rifampicin resistance, DST is again sensitive, that the whole genome sequencing didn't find any mutation and rifampicin was sensitive. Why was it resistant? Now, when we look at this was ultra, and we looked at the ultra graph. The ultra does a melting curve analysis of mutant probes and the wild probes. When we looked at the ultra graph, it suggested heteroresistance. Heteroresistance means you have two populations of sensitive and resistant in the sample. Heteroresistance was suggested by presence of both mutant probes as well as the wild probes. That's how we identified it's a heteroresistance. So sample showed heteroresistance, but the culture showed sensitivity, because when you culture the heteroresistant sample, due to the fitness cost associated with resistance, the bacteria which is susceptible will grow. The culture produces a susceptible growth, and when you do a DST of susceptible growth, you will find it to be sensitive. So whole genome sequencing also will come susceptible because you have grown a susceptible isolate. So that's the logic or reason that we gave for this particular isolate being Xpert resistant, heteroresistant phenotype, where both mutant probe and the wild probe were amplified. In the third case, you see rifampicin was resistant, DST was also resistant, and WGS also identified a mutation lineage 3, rifampicin was. Now, if you look at literature, these two mutations are resistant to rifampicin, but they are sensitive to rifabutin. If rifabutin is available, you can actually treat these patients with rifabutin. Rifabutin, I assume, is available in government setup for latent tuberculosis. If rifabutin can be used in such cases, if you know there's mutation and also know that this confers resistance to rifampicin, but they are sensitive to rifabutin. So that sort of detail can be only got when you do a whole genome sequencing and identify the mutations responsible for the resistance. Then this is a study. This is not an evaluation. This is a very beautiful study where they found that they can use whole genome sequencing to identify outbreaks. Now they sent 6 isolates. This lab in Korea sent 6 isolates for whole genome sequencing. The first and the 6th patient were smear positive. They had active tuberculosis, and they don't have any doubt that they are tuberculosis patients. But what happened to 2nd, 3rd, 4th, and 5th patient? They also grew Mycobacterium tuberculosis, and they were very skeptical why they grew a Mycobacterium tuberculosis when they didn't suspect TB in the first place. On whole genome sequencing, they found all were lineage 1. All had the same pre-XDR pattern, except for the number 6, which had a different XDR, pre-XDR pattern. So isolate number 1 to 5 had the same XDR pattern, pre-XDR pattern, and they were all lineage 1. And when they did a cluster analysis, they found that the isolate number 1 to 5 were clustered together because they had SNPs less than 10 SNPs. They are all identical. And isolate number 6, 1 and 2, that is 2 isolates of that patient, were clustered together. They were identical. So they came to the conclusion that clinically patients 2 to 5 didn't have any tuberculosis, but gave the same cluster, belong to the same cluster, means the lab has contaminated the specimens. So these patients didn't have tuberculosis. They didn't treat the patients for TB. They discontinued the TB patient TB treatment if it was initiated based on the whole genome sequencing study. By identifying that there was a cross-contamination in the lab, only patient number 1 and patient 6 were actual pre-XDR cases, and they went ahead with the treatment of these 2 patients. But that is the beauty of whole genome sequencing, where you can identify clustering, outbreak, and differentiate it with contaminant if you don't have a clinical correlation.